Thank you so much for the invitation. It's really a pleasure to be here today. I'm going to talk to you today about fertility preservation and cancer. And I'll go through the recent guidelines, including the NCCN guidelines that were published in 2012, some of the barriers to the implementation of those guidelines, which really still exist even several years after the guidelines have come out, patient attitudes towards fertility preservation, assessment of fertility risk, methods both current and coming down the pike for preserving fertility, optimizing institutional standard practice for fertility preservation, and then some tips on fertility counseling for patients. So there are unprecedented numbers of young cancer patients in the United States for several reasons. First of all, cancer incidence is increasing, particularly in young people, and mortality is decreasing over the past several decades due to therapeutic advances. Also, for reasons that aren't completely described, the incidence of second malignancies is increasing in the population. And thus, the burden of cancer in people of childbearing age is increasing. And in fact, in women, more than 1 in 50 women have cancer by the time they reach the age of 40. And in the United States and other westernized countries, childbearing is also increasingly delayed. And between 1990 and 2011, the birth rate for U.S. women between 35 and 44 years of age increased by 54%, while decreasing for women in their teens and late 20s. And thus, there's a greater need than ever for fertility preservation in medical oncology practices. So, guidelines. It's estimated that up to 90% of patients with cancer under the age of 45 are at risk for infertility related to their cancer therapy. And guidelines mandate fertility risk assessment and referral for all patients. The first guidelines that were published were the ASCO guidelines in 2006, and this is a copy of them. They say that all patients, men and women, who are at any risk of infertility related to their cancer treatment should be promptly referred. NCCN, the American Society of Reproductive Medicine, and now several European entities have also mandated fertility preservation for everyone in the last several years. These are the NCCN guidelines, and again, fertility preservation is an essential part in the management of AYAs with cancer, adolescents and young adults. And the NCCN guidelines state that fertility preservation should be discussed with all eligible patients and prior to the start of therapy, not afterwards. Patients who are interested in preserving their fertility should be referred to a fertility clinic within 24 hours, and providers should give consideration to whether they want to bring a mental health provider in for help with decision making, because it's been shown that that's beneficial to patients. And providers should be prepared to offer gender-specific counseling regarding risk to fertility with given cancer treatments and options for preserving fertility. Barriers to implementation. So the initial literature on this subject was published by Leslie Shover in the early 2000s, and she interviewed both medical and pediatric oncologists, and providers said, well, we just don't have enough time to discuss this topic right at the start of therapy. We're talking about treatment protocols. Providers said they were not comfortable discussing fertility preservation, particularly masturbation, with young boys who are minors. They didn't know what to do with patients with a poor prognosis. Would it be seen as a good thing or a bad thing if they offered fertility preservation? Or patients with developmental delay, again, people didn't know what to do about that. Also, many cancer centers back then and still didn't have close relationships with fertility clinics, so providers didn't know exactly where to send the patients. They were worried that it would cost money out of pocket, and were concerned about providing a service for some patients that others couldn't afford. Also, were concerned that even if they sent the patients to the fertility clinic, that the patient's fertility would already be impaired related to the cancer diagnosis at the time the patient was trying to preserve their fertility. And of course, providers are wanting to start treatment fairly urgently in many cases, and so the delay of chemotherapy is also seen as a barrier. So several months ago, I reviewed the literature again in the high hopes of finding that these practices had changed over the past several years. And unfortunately, even very recent publications, which usually have data analyses a couple of years ago now, still really indicate that most patients are not being successfully offered fertility preservation in most oncology clinics in America. So in a 2012 chart review, there was no difference in fertility preservation offerings to patients before and after the 2006 ASCO guidelines were published, and actually only 21% of eligible patients of childbearing age were referred. Another 2012 survey of medical oncologists said that 95% of providers routinely discuss infertility with their patients, but 61% rarely or never refer patients for fertility consultation, and 30% of providers rarely consider a woman's desire for future fertility when thinking about planning her cancer treatment regimen. And surveys of pediatric oncologists are similar, with less than 50% referring any patients and only a small minority of female patients referred for treatment. There are also disparities in who's offered fertility preservation, and those disparities are on the basis of race, gender, age, and sexual orientation. So a study of 231 cancer patients between 18 and 45 years of age showed that risk to fertility posed by the cancer treatment and fertility preservation options were discussed in only about a quarter of cases, and less than 20% of patients were referred. And discussions of fertility risks were less likely to occur if the patient was Hispanic, if the patient was female, if the patient was a breast cancer patient, if the patient was over 40, or if the patient had children. Now, studies are mixed. In another study in a different hospital, patients in the breast cancer clinic actually were more often referred to fertility preservation clinics than patients with other diagnoses. So it's very interesting how just locally dependent this is. If there's a champion in the clinic who will perform this service, and if the clinic is set up to do so, then it happens, and otherwise it's unlikely to. Other studies show referral bias against gay men and also non-heterosexual women, despite the fact that there were no differences in the childbearing goals for the non-heterosexual women compared to heterosexual. Now, a question? So following publication of the ASCO guidelines for fertility preservation in 2006, most patients of reproductive age now take steps to preserve their fertility prior to the start of cancer treatment. True or false? False, 87% is correct. Another question. A 42-year-old married man is diagnosed with glioblastoma. Due to his poor prognosis, it is not advisable to offer him sperm banking. True or false? False. Again, is correct, because prognosis should not be a determinant to who's offered sperm banking. Even patients with poor prognosis cancer may potentially survive, and so it's not fair to withhold the offer of fertility preservation based on prognosis. Patient attitudes about fertility preservation. So infertility, when patients are surveyed, often comes as a real shock to cancer patients. And young adults say they really had no idea that this was going to happen. And this is possibly as a result of the fact that not all providers are actually discussing the potential for infertility in their clinic. Also potentially because of recall bias and the fact that the discussions of infertility come at the time of diagnosis when patients are really upset and not thinking very clearly. And not only is infertility a lack of the ability to have children, but some patients may also perceive it as a loss of masculinity and femininity, and can have a lot of psychological issues related to that. And adoption services are, of course, a possibility, but surveys show overwhelmingly that patients really want to have their own biological children if at all possible. This is a German study of young survivors ages 18 to 45 years of age who are several years post-therapy for Hodgkin's lymphoma, showing that 75% of patients who were childless at diagnosis wanted children. And even several years after therapy, patients who had not said they wanted kids at the time of diagnosis now did want children, really bringing the number of patients wanting children in this young age group over 90%. And unfortunately in this study, a third of patients had already had difficulty conceiving, and those who had problems with infertility also had moderate distress. Perceptions of men regarding sperm banking are overwhelmingly positive, and these data have all been collected really within the past decade. Even men who never used their samples or declined to bank or tried to bank but were not successful generally feel that sperm banking is helpful to them in their emotional processing, and it kind of offers hope and something positive even if the prognosis is poor. It helps them think toward the future, toward the end of their cancer therapy. And 96% of adult males would recommend sperm banking to other patients. Now, it's important to mention that most cancer survivors can have healthy children if they're fertile. Of course, patients with genetic cancer predisposition syndromes do have an increased cancer risk in their progeny, but cancer and cancer therapy and fertility interventions don't increase the risk of cancer or congenital anomalies in offspring above the baseline rate of all patients receiving assisted reproductive technologies. Infertility causes lots of distress in young adult cancer patients. Women report a bit more fertility-related distress than men, and the levels of this distress are highest in women who are younger, non-white, and childless, and women who receive chemotherapy. In men, those who had not banked sperm and were concerned that they were infertile reported more conflict in their intimate relationships, more risky sexual behavior, lower self-esteem, and concern about being rejected. So there are wide and far-ranging problems associated with infertility in this population of cancer survivors. Now, studies report that patients report more favorable psychological outcomes when they are able to participate in their own decision-making along with their healthcare provider. So the perception of being involved in decision-making really is important to patients. And patients also state that they're strongly influenced by their healthcare providers when making fertility decisions. And so provider attitude matters, and thus the oncology providers' positive attitude and help in getting the patient to the fertility clinic is really very key at the time of diagnosis. Assessment of risk. This is probably the slide with data that you're most familiar with, and we all know that both chemotherapy and radiation therapy can increase the risk for infertility. Alkylators are a big offender in causing infertility, and of course other agents can also cause infertility, including non-classic alkylators, heavy metals, newer agents, and radiation therapy, especially to the brain or gonads. And higher doses of chemotherapy using multiple agents and combining particularly radiation therapy with alkylators poses the highest risk for infertility. Now, there are a bunch these days of guidelines and online assessment tools that providers can use to predict fertility risk in a given patient once the therapy has been decided. Fertile Hope has a nice online risk calculator for more pediatric type diagnosis. The Children's Oncology Group long-term follow-up guidelines are good. ASCO has guidelines, and multiple review articles in the past 5 years or so address this topic. The problem is that for any one patient, it's very hard to predict with certainty what their risk for infertility will be. So risk categories that are commonly used are quote-unquote high risk for infertility, which is often stated as greater than 80% risk of long-term infertility, or prolonged azoospermia, depending on which guideline you look at. Intermediate risk, which I find really the most problematic, is a 20 to 80%, or sometimes a 30 to 70% risk of infertility, depending on, again, which guideline you look at. And other guidelines say that men are likely to have prolonged azoospermia, or may have, but is not common at the standard dose. And then low-risk protocols confer less than 20% of a risk of long-term infertility, but even 20% is a major psychological issue for some patients and a major concern. And azoospermia in the low-risk protocols is usually thought to be temporary and reversible after an indefined period of time. So risks to fertility in males and females are different, and I think of them as almost opposite. So men generally, if they're going to be infertile, are infertile for a period of time after their cancer therapy, after which they may or may not regain their fertility. In contrast, usually even with fairly high-dose chemotherapy, if the woman is young, have at least a little bit of a window of menstrual cycling, at least after their chemotherapy, but they are at risk for decreased ovarian reserve and premature ovarian failure. So for males, cancer itself can cause low sperm counts, particularly in diseases like Hodgkin's and testicular cancer. And chemotherapy and or radiation can decrease sperm production and cause damage to the sperm in many different ways. Surgery to the reproductive organs obviously can damage fertility, and the factors that determine the likelihood of reproductive damage include what type of chemo you got and how much, where the radiation was and how much, the patient's pubertal status at the time of treatment, with prepubertal patients possibly, but not definitely, being somewhat protected against infertility, and also the patient's pre-treatment fertility. So 15 to 20% of couples in the U.S. population are infertile, and that can come either from the male or the female side. So there's a significant baseline risk of infertility within the population even before cancer treatment. So males are at risk for azoospermia of variable duration, and it's important to remember that just because the patient appears well virilized does not mean that he's fertile. The Leydig cells, which produce testosterone, are much more resistant to injury from chemotherapy than the germ cells are. And so sperm can be completely destroyed and the patient may still appear well virilized and yet be infertile. And there's a potential for natural recovery of sperm count, which has been reported even up to 13 or 14 years following chemotherapy. Lance Armstrong is an excellent example. He required his banked sperm to conceive his first 3 kids after his testicular cancer diagnosis, and more than a decade after he was treated, he was able to conceive 2 children naturally. For females, the risk is for irreversible premature ovarian failure. And just like males, the damage to the ovaries depends on the drug, the dose, and the woman's age. Women in their 30s are much more susceptible to ovarian failure than younger women because of decreased reserve in the decreased ovarian reserve that's age-related. Younger women may be somewhat more protected, but of course they're at risk for a shortened reproductive lifespan, and it is very difficult to predict when premature ovarian failure will take place. In a study of very young women who had received alkylating chemotherapy and radiation under age 20, 42 of them had reached menopause by 31 years of age compared to only 5% of healthy controls. And the theory is that cancer therapy reduces the primordial follicle reserve, so that a woman starts here and has a normal ovarian reserve, then gets some chemotherapy and goes to a lower baseline that decreases with age, such that she might reach menopause, in her 40s instead of 50s, or, if it were lower, perhaps in her 30s instead of early 50s, as other women do. And survivors may have a follicular depletion despite recovery of regular menstrual cycles, so regular menses do not mean a woman's fertile. Now I'll talk about methods of preserving fertility, first for females and then for males. So for women, there are a few surgical options to preserve a woman's fertility. One is to preserve the reproductive organs during cancer surgery whenever possible. So if ovaries can be spared, if the uterus can be spared, that's obviously helpful in a woman having her own children later. Ovarian transposition and oophoropexy are slightly different surgical procedures that have the exact same result, which is to move the ovary out of a radiation field prior to the start of planned radiation. And this can reduce the ovarian radiation dose by up to 95%, but unfortunately doesn't always preserve fertility. In some studies, 60 to 89% of young survivors maintained ovarian function following this procedure, but some studies suggest that actually the real rate may be lower. And even if the fallopian tube is stretched quite a bit, which is physiologically possible, patients may be able to conceive normally, but if the ovary is actually moved away from the proximity of the fallopian tube, people may require in vitro fertilization to conceive. So the established methods of fertility preservation for females these days include embryo cryopreservation, which has been the gold standard for decades, and also oocyte cryopreservation, which became standard of care according to the American Society of Reproductive Medicine in 2012. Since 1999, there have been over 2,000 live births using this method, and cancer patients have been the primary population studied, increasingly the procedures also being used for older single women who just want to preserve their fertility following their mid to late 30s if they haven't yet found a partner. So it's now commercially available on the market outside of a clinical trial. The new ovarian stimulation protocols take a whole lot less time than the older ones. They don't depend on the stage of the menstrual cycle. They can be started anytime, and they take about 10 days to 2 weeks for completion. So if a woman's going to preserve her fertility either by oocyte or embryo cryopreservation, she has to be able to wait at least 2 weeks before starting chemotherapy if her cancer treatment allows that and her clinical status. Oocyte cryopreservation is increasingly being used by young BRCA mutation carriers who may undergo breast reconstruction and also bilateral salpingo orophorectomies at a young age. And so oocyte cryopreservation is a nice option for patients like that who don't yet have a life partner in mind. Oocyte cryopreservation is also an option after the completion of chemotherapy. Usually it's recommended to wait at least 6 months after chemo is completed before attempting to harvest oocytes, but that's not really based on any great data, just the supposition that chemotherapy can harm developing oocytes. And the live birth rate for both methods is quite good and actually equivalent to fresh in vitro fertilization cycles. The efficacy of embryo versus oocyte cryopreservation has been compared and is equivalent in multiple studies. Long-term oocyte freezing is very effective and doesn't cause embryonic aneuploidy. Again, is comparable with fresh cycles of IVF. Both procedures are similar. Both cost $11,000 or $12,000. The cost is trending down over time, but still fairly high, and these are generally out-of-pocket costs for women. And again, when estimating the likelihood of success with either oocyte or embryo cryopreservation, you have to take into account the patient's age, her estimated ovarian reserve, and her previous treatment status. Women in their late 30s and older are really much less likely to be successful with those procedures. Ovarian tissue cryopreservation and followed by transplantation is an interesting procedure that is coming down the pike and remains experimental at this time. So what's done in this procedure is a laparoscopic retrieval of little squares of ovarian cortex, which are then frozen down, and following the completion of cancer therapy and recovery of the patient, they can be regrafted onto the ovary, which could allow for natural conception, or the pelvic wall or abdominal wall from which the oocytes could be harvested and then implanted by in vitro fertilization. And there have been more than 37 babies born with this method since 2004. And some patients have had complete normalization of both their hormonal levels and their fertility with this procedure. So it's a pretty exciting possibility for the future. It does have risks, however. You can get ischemic damage to the squares of ovarian cortex with the freezing and thawing method. There's also a concerning potential of transferring malignant cells during the procedure, and this has been reported in a patient with leukemia, which is not surprising given that in female leukemia patients, even if they have no histologic evidence of involvement, you can detect cancer cells by PCR in up to 70% of patients with leukemia. And so this procedure is contraindicated in patients with leukemia and also obviously ovarian cancer. Now, malignant cells are seen on autopsy in up to 55% of women under 40 who die of cancer, so there's a theoretical risk of transferring metastatic cells in women with any cancer, although people who have apparently localized disease are somewhat unlikely to have that happen. But it's impossible to predict. The advantages are many. It could be used in prepubertal patients, potentially. The freezing of ovarian cortex can yield a large number of oocytes that could potentially be used later, many more than you could get from a cycle of ovarian stimulation followed by the freezing of single oocytes. And there's less potential delay in starting the cancer treatment because you can just do the surgical procedure, freeze down the cortex, and then start therapy without needing drugs to stimulate ovulation. And many conceptions using this method, again, are unassisted, which is really nice and saves money on the back end. Another exciting possibility is the in vitro maturation of primordial follicles into fertilizable oocytes. And this would potentially eliminate the transfer of tumor cells along with the ovarian tissue. And you would be able to, just get a mature egg from the sample and then use that for in vitro fertilization and deliver just the embryo back into the mother. And this procedure would also allow oocytes to be preserved from prepubertal girls and women who couldn't delay their treatment for a couple of weeks in order to bank embryos or oocytes. So exciting for the future, not yet ready for prime time. When cancer patients undergo ovarian stimulation, they actually have quite good results. So if you do an IVF stimulation cycle in an infertile woman, that woman and a cancer patient will have roughly equivalent rates of success. Although it has been reported if you compare different cancers with each other that patients with hematologic malignancies have fewer oocytes retrieved than patients with breast cancer, for example, related to the probable underlying fertility problems with hematologic malignancies. Another really exciting potential way to preserve fertility in women is GnRH analogs. This is gonadotropin-releasing hormone agonists and antagonists. They have been used for decades in cancer patients. The idea is to stimulate the prepubertal hormonal environment by decreasing ovarian perfusion and kind of shutting down the pituitary ovarian hormonal axis, which in theory would limit direct cytotoxic damage. The very first studies that show definite benefit have just recently been published, and I'll show you those in a minute. Just in the last couple of years, there have been a number of meta-analyses, the majority of which show benefit and a decrease in premature ovarian failure. 9 studies do not support the use of GnRH analogs. However, all of these used only amenorrhea as a surrogate for female fertility following cancer chemotherapy, which, as I'll show you in a minute, is really not very accurate. The use of GnRH analogs is supported by 7 meta-analyses, including a recent Cochrane meta-analysis. And these show that menstrual function is preserved in 91% of treated survivors versus 41% of controls. But even more importantly, fecundity is increased with pregnancy in 19 to 71% of treated survivors with an odds ratio of 12.87. And also, anecdotally, older ages of pregnancy reported in treated women, which suggests that if they do have premature ovarian failure, it's happening to them later than other women. The POEM study, SWOG S230, was a phase 3 randomized study that recently finished and tested an LHRH analog given along with chemotherapy and found that the use of gozrelin led to less premature ovarian failure and more pregnancies. So there were 257 women aged under 50 with ER/PR positive or ER/PR negative breast cancer. And they received either standard cyclophosphamide-containing therapy or standard chemotherapy plus weekly subcutaneous dosing of Gosrelin, the LHRH analog, given beginning 1 week prior to the start of chemotherapy. The primary endpoint was premature ovarian failure at 2 years, as measured by amenorrhea and a postmenopausal FSH level. And 22% of treated patients versus 8% of untreated patients the premature ovarian failure was less in the untreated patients. Now, if you looked at either amenorrhea or elevated FSH as an endpoint, then 45% versus 25% of patients had premature ovarian failure with the benefit for patients on the Gosrelin arm. Excitingly, the patients on the treatment arm also had more pregnancies with an odds ratio of 2.22 for getting pregnant following therapy, and as an unexpected result, they also had an improved disease-free survival. The mechanism for that has not yet been explained. How do you use GnRH analogs clinically right now? They are safe for all diagnoses, including breast cancer. They're used in parallel with chemotherapy and with other fertility preservation methods, and they can be used to prevent menorrhagia that's associated with thrombocytopenia. So the ASCO guidelines recommend it in addition to other fertility preservation strategies. So as I mentioned previously, measuring ovarian reserve is really hard in women, and if there was a way to do it accurately, it would be extraordinarily helpful in helping women predict whether they needed to freeze down some eggs or embryos because they were going to be infertile early, or whether they could just wait a few years before attempting to have kids. AMH, anti-Müllerian hormone, is a hormone produced only by the primordial follicles in the ovary. After menopause or oophorectomy, the level falls to 0, and the level doesn't vary significantly with the menstrual cycle. It's thought to be a good indicator of total ovarian reserve. Now, at diagnosis, AMH levels in cancer patients are similar to age-matched controls, but in women with hematologic malignancies, they tend to be already low, again suggesting some cancer-related infertility in those patients. For patients on therapy, levels of AMH typically fall quite dramatically in the first few weeks of cancer therapy, both in premenopausal women and in girls, suggesting that growing follicles are damaged by the chemo, which is expected. At end of treatment, all patients tend to have low levels, but then post-therapy, there is improvement in AMH levels in some but not all patients, and higher pretreatment AMH level tends to predict higher post-treatment AMH level and presumably thus better long-term ovarian function. AMH levels therefore are thought to correlate with chemotherapy toxicity. Recovery of AMH has been shown to be more prolonged with higher intensity chemotherapy protocols and with regimens containing alkylators, suggesting a greater depletion of ovarian reserve with these treatments. Hopefully in the future, AMH may be used clinically to predict individual risk of chemotherapy-induced premature ovarian failure, but again, it's not clinically used at present, pending validation. Let me show you a few studies that look at AMH following chemotherapy. So, as I said, it's known that low AMH correlates with low success in vitro fertilization, and that's even in populations without cancer. Also, it has been shown that recovery of AMH decreases with increasing age following chemotherapy. In this study, it was Hodgkin's patients. So the percent of patients who had AMH levels that were less than 1 increases with the increasing age of the patient between less than 30 and the late 30s. So the question is, to what degree does a low AMH actually predict infertility in cancer survivors? And that is the question that hasn't yet been answered yet. So even women who resume menses after chemo are at risk for premature ovarian failure, depending on what kind of cancer they have, what kind of treatment they have, and how old they are when they're treated. And again, patients may resume menstrual cycling yet be infertile. Studies are mixed, however, on to what degree a low AMH post-chemotherapy predicts the lack of fecundity or future infertility. In the youngest women in their 20s, they may have a fairly low AMH and yet conceive. However, there is a much stronger correlation in older premenopausal women in their 30s between fecundity and AMH levels, with higher AMH levels predicting higher fertility. So in summary, fertility preservation has some good options that are available at present and many good options coming down the pike for women. However, it's still used only by a minority of women with cancer who are at risk for infertility. This is a recent multi-center cohort study that was published just a couple months ago. However, the data was collected in 2011. It showed that only 11% of women in one center used fertility preservation, but that the proportion had increased from 5% to 15% between 2005 and 2012. Only a small number of patients used embryo or oocyte cryopreservation, and there was a GnRH agonist intervention that was a clinical trial, and some patients used that. However, almost 20% of patients based some treatment decisions on their future fertility choices. For example, some of them refused endocrine therapy, or some chose one chemotherapy regimen over the other with the hopes of preserving their longer-term fertility. A few new developments on the horizon that we haven't talked about. So at present, from a clinical standpoint, it's not possible to preserve fertility in prepubertal children, but hopefully ovarian and testicular tissue cryopreservation will allow that in the near future, and those strategies are in clinical trials right now. In vitro maturation of gametes we discussed. Those could be done in conjunction with ovarian cortex processing, or separately. The oocytes could be retrieved and processed immediately without being frozen down. Uterine transplants are something pretty new. They can be either live or cadaveric, and the first live birth in a human was reported in late 2014, so that's a new technology. Autosomal pluripotent stem cells are also currently being used in animal models, not yet in people. Ongoing challenges include improving the safety and ensuring that there's no transfer of malignant cells along with gametes, and transition from experimental to clinical use. Now a question. Which of the following is not true regarding GnRH agonists, analogs? A, they prevent menorrhagia associated with thrombocytopenia. B, use is recommended by ASCO guidelines. C, they're safe for breast cancer patients. D, they should not be used concurrently with other fertility preservation strategies. Or E, they're used in parallel with chemotherapy. Great. So 71% of people got the right answer, D. It is not true that they shouldn't be used concurrently with other fertility preservation strategies. In fact, they should, and it's safe to do so. And then reserve of primordial follicles correlates with all of the following except A, age of diagnosis, B, type of cancer, C, AMH level prior to the start of therapy, D, AMH level at the end of therapy, and E, AMH levels 5 years after therapy. So the correct answer is D, AMH level at the end of chemotherapy. AMH level prior to the start of therapy is a reasonable predictor of AMH level as a long-term survivor, although of course the chance of the AMH level and the fertility being decreased depends on the age of the woman and the type of the treatment. However, the AMH level at the end of therapy is low for most patients. So now we'll talk about fertility preservation options for guys. Sperm banking is far and away the gold standard. It entails generally a trip to the sperm bank and masturbation to obtain a semen sample. Fertility clinics usually like to have men come in 2 or 3 times if possible to bank sperm in adequate numbers to give them a couple of kids in the future with assisted reproductive technologies, usually with IVF. Men who are younger, men who are more educated, and men who are childless are the most likely to bank sperm. It's also worth noting that in recent years it has become feasible to mail in sperm samples to be frozen down, and Livestrong offers something called the Live On Kit, which is a nice resource for men who live in remote locations where they can't easily get to a sperm bank before the start of therapy. So those can be ordered and are a nice resource. Testicular sperm extraction is much less often used. It entails under anesthesia in the operating room using a syringe to kind of suck out some semen from the testes, and has actually been associated with very good sperm collection in early pubertal males and also men with azoospermia. In that population, the sperm that are collected, even if they're not motile, can be used for ICSI, and some men can become fathers that way. Electroejaculation allows a semen sample to be collected by vibratory stimulation, and that actually is a very well tried and true method in animal husbandry. It's used all the time in veterinary medicine, etc., in zoos. So if you search it, you'll get a lot of animal references. Less often used in men, but it's totally feasible. Often done in the operating room when they're getting a port or something, patient under anesthesia. Although it wouldn't have to be theoretically. Testicular tissue preservation, again, is experimental and currently being looked at in high-risk pediatric cancers. So this is a nice male fertility preservation algorithm, which just shows that if masturbation is possible, the guy should go to the sperm bank and bank sperm. If it's not possible, one could try vibratory stimulation and electroejaculation. And if that's not possible, peripubertal men or azoospermic guys could have biopsy. This is testicular sperm extraction. And for prepubertal boys, the only option is biopsy and cryopreservation of testicular tissue at present. Now, it's worth noting that the best time to bank sperm is before starting therapy. This is a study of young men on a low-risk protocol for leukemia who hadn't banked initially because they were told they had little risk of azoospermia, but then their leukemias relapsed and they attempted to bank prior to bone marrow transplant. And as you see, the majority of patients have either azoospermia or oligospermia, and some were unable to produce a semen sample. Only about 30% of them had a sample that was successfully collected. So the conclusion was the best time to bank sperm is before starting therapy, and even for patients on low-risk protocols, you can't assume that collection will be normal later. Another question? The following fertility preservation method is still considered experimental. A, oocyte cryopreservation, B, GnRH analog use, C, ovarian tissue freezing, D, electroejaculation, and E, sperm banking. Good, 70% of people got the correct answer, which is C, ovarian tissue freezing is still experimental. Finally, I'm going to talk about some ways that institutions can optimize their standard practice to support fertility preservation in young patients, and also give some tips for fertility counseling. This is a recent study that looked at NCI-designated comprehensive cancer centers, so the cancer centers from everyone here in the room. They asked all of the centers that saw adult patients to give interviews. About 3/4 of them agreed to this. The remainder either refused to be interviewed or actually didn't have any fertility preservation services. So of the respondents, about 2/3 offered some services for fertility preservation on site, or they had referral programs that were established. A little less than half offered experimental service, such as ovarian tissue cryopreservation. 27%, less than a third, had any dedicated staff to do fertility preservation counseling, and only 13% had institutional policies regarding consistent provision of information. And so the the conclusion of this study was that comprehensive cancer centers are positioned to provide exemplary oncofertility care, but most need to better integrate fertility preservation information and referral into practice. And it certainly is true that guidelines can easily state, yes, this should be done, but actually offering fertility preservation requires FTE, requires somebody's time and money and institutional support. So here are some ideas for how to initiate those things if you don't have them already in your institution. I was at Seattle Children's for 7 years and founded the AYA oncology program there. And one of the very first things we did was to address fertility preservation. We had done some background research that showed that only 7% of eligible guys were being referred for sperm banking. And so clearly there was a long ways to go. So what we did was to hold a stakeholders workshop to develop and implement a reliable method for screening and offering sperm banking to all eligible patients. And the other goals were defining who was responsible for the conversation about fertility preservation, to figure out how to standardize the documentation, because if you don't write it in the chart, it never really happened. And it's important to have that documentation, to create educational resources both for patients and for providers, to schedule training for the providers so that everyone from physicians, fellows, nurse practitioners down to the nurses on the floor could understand what the new practice was, and then to track appropriate methods and solidify collaborations with the local fertility clinics. So the process that we envisioned was the oncology provider would have a short discussion with the patient in which they discuss the risk for fertility posed by chemotherapy, standard practice anyway at the beginning of cancer treatment, and document that conversation in the chart. And then have a brief discussion about how urgent it is to start chemotherapy, and also that there is the potential to preserve fertility prior to the start of cancer therapy. The patient's then given a written handout and watches an informational video. We actually have videos on the Seattle Children's website and also on YouTube for male and female fertility decision making to be used as a decision tool, and those are freely available and about 10 minutes long each. And then we would have the fertility preservation team, a dedicated set of providers, see the patient within 24 hours, document that, and then coordinate the sperm banking referral. And the fertility point person is to be knowledgeable about fertility preservation options, the cost, the financial assistance that's available. Patients can get assistance through Livestrong, Fertile Hope to defray the costs of banking. And they need to be skilled in sensitive discussions, be able to facilitate appointments and communication with the fertility clinic, assist the patient in their decision making, and track metrics. And so we said that the fertility preservation team would see all eligible patients within 24 hours of the consult. And for men, sperm banking were offered for guys. And these, the criteria for being offered sperm banking were that the patient was postpubertal, had no physical limitations to masturbation, i.e., if he was paralyzed from the waist down, that would be a physical limitation, and does not need to start therapy emergently. And testicular sperm extraction was an option for peripubertal guys. For females, they had to be postmenarchal and be able to delay the start of therapy for 2 to 3 weeks for the possibility of oocyte cryopreservation. So again, we started with less than 8% of patients being offered sperm banking who were eligible. And within the first 12 months of the initiation of the new standard practice, we went up to 90% of patients being offered the opportunity to bank sperm, and about 70% of patients taking us up on that offer, going to the sperm bank and trying to give a sample. And those levels were maintained over time with the institutional system in place. Question? The majority of NCI-designated comprehensive cancer centers have institutional policies regarding fertility counseling and referral. False is the correct answer. Only 13% of NCI-designated cancer centers have institutional policies regarding the provision of fertility counseling and referrals. So still a lot of work to do. Now a few words about counseling before we finish. So at Seattle Children's, as our group of providers on the fertility preservation team got comfortable with the counseling, there were a bunch of pretty quick lessons learned. I think the most important thing was the normalization of the experience, to be able to go into a room and say, this is something we standardly offer to every single adolescent young adult male, and we're offering it to you too. Seemed to make the patients and the families feel much more comfortable that this wasn't something weird that you were talking to them about, but just something that was, a normal part of the beginning of their cancer therapy. And there are ways to make the patient feel as comfortable as possible. You obviously have to have the conversation in a private setting. The provider has to be very familiar with the information and comfortable with it. If the patient seems uncomfortable, it's fine to just acknowledge that this can be difficult and that you only have to have this conversation once, make a decision, and that's it. And if you can give the patient some choices along the line as to who's present for the conversation, for example, that can be helpful. Financial considerations are worthy of mention because fertility preservation is still not covered under most insurance plans in the context of cancer. So infertility is actually seen as an iatrogenic consequence of cancer therapy, and so at the time that patients need to preserve their fertility, they're not yet infertile. And there are no states currently that mandate coverage for fertility preservation for cancer patients prior to treatment. So there is a cost to patients who want to preserve their fertility and have that baby. Implications for survivorship care are a few. First of all, infertility has long-term implications and can cause distress and impaired quality of life for many years after the cancer diagnosis. Studies show that when fertility counseling was not provided, patients reported lower self-esteem, regret for not questioning their doctor about infertility risks themselves, guilt for not being able to provide kids to their current partner, and fear of never finding a partner if they're not coupled up. And when fertility counseling was provided, women reported less regret and better quality of life. It's a study just of women survivors. So providers should address infertility concerns early on, post-therapy, and certainly an important thing to be discussed. Have you done fertility preservation, and if not, what are the options right now? And refer patients that are distressed for counseling earlier rather than later. So post-treatment options, again for females, include assessing ovarian reserve using AMH to try to predict what their window of fertility will be following cancer treatment, with the caveat that that's not very accurate in this day and age. And oocyte or embryo cryopreservation could be attempted a few months after the end of chemotherapy if the woman seems to be cycling normally. For males, testicular sperm extraction is an option for men who remain azoospermic after cancer therapy. And it is also worth mentioning in the context of this subject that sexual health and functioning should also be a routine part of cancer care for adolescents and young adults, older adults as well. And that particularly for young adults, it's good to remind them that chemotherapy is not birth control, and the fact that they might have infertility related to their cancer therapy doesn't mean that they don't need to worry about birth control during their cancer therapy. And that's it. I'm happy to take questions.